Hello to our listeners and welcome to the CardioVisual app. I am Ralph DeFronzo and I am Professor of Medicine at the University of Texas Health Science Center in San Antonio, Texas. And I also serve as Chief of the Diabetes Division. For those of you who don't know my background, and in addition to endocrinology and diabetes, I'm also board certified in nephrology. So today I'm going to wear my nephrology hat. Today we're going to talk about renal outcome trials in type 2 diabetes, implications for therapy. Diabetic nephropathy is very complicated with many pathophysiologic disturbances. So we're going to need multiple drugs for the treatment and prevention of diabetic kidney disease. We already have the ACEIS and the ARBS. Everybody knows this is very well established. And now we have the SGLT2 inhibitors. Now, what I didn't point out was that in order to get in to the CREDENCE study and the DAPA-CKD study, all of the patients had to have background therapy with an ACE or an ARB. So the data that I showed you with the SGLT2 inhibitor studies in CREDENCE and DAPA-CKD is the benefit of the SGLT2 inhibitor above and beyond that you would see with an ACE or an ARB, meaning you can use these two drugs in combination. Now, most recently, and I will review this study with you in a moment, we've had a very nice study with FINERENONE, FIDELIO study. This is a mineralocorticoid receptor antagonist, which really doesn't cause much in the way of hyperkalemia and does not cause gynecomastia, which are potential side effects with the currently available mineral receptor antagonist. The data from this study are very impressive, and I believe will allow it to be approved by the Food and Drug Administration. We also have some preliminary data with the GLP-1 receptor agonist. I'm a little bit less convinced at the present time that they're going to give us renal protection on a long-term basis, but I'll take you through the data that are out there. So let's just take a look at the FINERENONE study. This is Dr. George Bachrus' study in the New England Journal of Medicine, recently published. The renal composite outcome is shown in the panel to the left. This is end-stage renal disease, dialysis transplantation, a sustained decrease in GFR to less than 15 or greater than 40% reduction in GFR or renal death. Hazard ratio is 0.82, meaning 18% reduction in this renal composite outcome. Now, the secondary outcome was a cardiovascular outcome. You can see to the right. So this is cardiovascular death, non-fatal MI, non-fatal stroke, hospitalization for heart failure, hazard ratio 0.76. So remember, as I pointed out at the beginning, cardiovascular disease and renal disease go hand in hand. So SGLT2 inhibitors give you renal cardiovascular protection. FINERENONE also gives you renal and cardiovascular protection. This drug will be reviewed by the FDA and hopefully approved, adding another drug to the armamentarium of our approach to the patient with diabetes and chronic kidney disease. Now, what about the GLP-1 receptor agonist? This is a meta-analysis of 5 trials which have data looking at a composite renal outcome, including macroalbuminuria. And you can see in this meta-analysis, the hazard ratio is 0.83, and it was statistically significant. However, proteinuria is really not that solid of an endpoint from the standpoint of the kidney. So if you now reanalyze these data and you look at worsening kidney function and taking out macroalbuminuria, the hazard ratio is 0.87, and it does not quite reach statistical significance. So I think that the sort of conclusion in terms of how effective the GLP-1 receptor agonists are going to be in terms of preserving renal function and preventing the decline in GFR remains to be seen, but there are ongoing studies with a number of these drugs to look if they will indeed provide renal protection. So in conclusion, the treatment of established kidney disease is going to require aggressive intervention with multiple medications. We have the ACEIS and the ARBS, we have the SGLT2 inhibitors. We actually do have data with aldactone and spironolactone, and hopefully soon we'll have FINERENONE approved. We'll have to see what happens with the GLP-1 receptor agonist. Now, if we really want primary prevention of diabetic kidney disease, this means keeping the A1C less than 6.5, okay? If you don't let the A1C go up, you're not going to develop the microvascular complications. You'll prevent diabetic nephropathy. We also need very aggressive antihypertensive therapy, and the more recent KDIGO guidelines mean the blood pressure should be less than 120 to 25 over 75 to 80. And we need to be using these renal protective drugs that we've just talked about, in particular the SGLT2 inhibitors, because they're already approved, very early. And I would suggest that we need to be starting as soon as you make the diagnosis of diabetes. Why? These drugs are very good at lowering your A1C. These drugs give you cardiovascular protection. These drugs give you renal protection. There's no reason to believe that these drugs are not working early on the kidney to prevent diabetic kidney disease as they are working late. So although we'll probably never have a study that looks at what happens to renal disease starting from the diagnosis, day one of diabetes, there's no reason to believe they're not doing the same thing in terms of kidney protection. And as I said, they're giving us cardiovascular protection. They're good for lowering the glucose. So in my opinion, these drugs should be considered as first-line therapy in the treatment of patients with type 2 diabetes.